like to introduce Dr. Rayan Yousefzai, who's an advanced heart failure specialist at Houston Methodist, and I think he's nicely positioned to highlight which is a real complexity in this patient population, both pre-shock, shock, overt shock, and that's cardiorenal syndrome. Ryan, appreciate you being here. Looking forward to your talk.
Thank you, Jerry, and thank you for the opportunity to talk in this very impressive conference of a lot of people. My disclosure, I'm a site PI for a venous HF trial, but no other relevant financial disclosure. So I have 10 minutes to talk about the cardiorenal syndrome. I just want to highlight the definition of the cardiorenal syndrome, which has been refined over years. In 2004, the National Heart, Lung, and Blood Institute defines the cardiorenal syndrome as interaction between kidneys and other circulation department that increase circulating volume and exacerbate the symptom of the heart failure. Over years, that has been refined. In 2008, there was two major groups identified, cardiorenal and renocardial, based on the primary organ involvement, and that has been more refined now to 5 groups with the current classification. What are the 5 groups? These are 5 types of cardiorenal syndrome. Type 1 is the acute cardiorenal syndrome. This is heart failure resulting in the acute kidney injury. Type 2 is a chronic cardiorenal syndrome. This is a chronic heart failure, which is resulting in the chronic kidney disease. Type 3 is the acute renal cardiac syndrome. This is acute kidney injury, which is resulting in acute heart failure. Type 4 is a chronic renal cardiac syndrome, chronic kidney disease causing chronic heart failure. And type 5 is a more systemic process, which is a secondary cardiorenal syndrome, such as amyloidosis, sepsis, or cirrhosis. For the purpose of this talk, and especially as a cardiology provider, we mainly deal with this type 1 cardiorenal syndrome, especially in the setting of the heart failure and acute decompensated heart failure. So as we know, the interaction between heart and kidney is complex and through different pathways, including hemodynamic, neurohormonal, inflammatory, and oxidative stress. Why we talk about the cardiorenal? Because it has a mortality and outcome relevance. There's an increase of 15% increased mortality for every 10 millimeter per minute reduction in the GFR. The prevalence of the moderate to severe kidney disease is about 30 to 60% in the patient with a heart failure. And 30% of the patient who will undergo treatment for a heart failure or acute decompensated heart failure will develop increased serum creatinine. And as the graph that shows, there's an exponential increase of the composite endpoint of death, rehospitalization, and dialysis based on the worsening of the kidney function. So the treatment is usually focused on the threefold: decreasing the preload, decreasing the afterload, and increased contractility. The decreasing preload has remained the cornerstone of treatment for the patient with acute decompensated heart failure. And why is that? If you look at the hemodynamic parameter, CVP was the only hemodynamic parameter this is clearly associated with the worsening of renal function. Even though other parameters are important and we need to look at them and treat them, but as far as the worsening of the kidney function, CVP was the most relevant hemodynamic parameter. So the diuretics still remain the cornerstone of the decongestion of this patient, and loop diuretics are the most commonly used, such as furosemide, bumetanide, and torsemide. However, the strategy of using still is not very clear, as the famous dose trial that we looked at the different strategies, bolus versus continuous intravenous infusion, low dose versus high dose. The primary endpoint of the global clinical assessment and the change of creatinine was not different between different strategies. And as far as the follow-up, so this 60-day follow-up with a composite endpoint of hospitalization, death, and emergency visit was not different between those two groups. However, of course, as we know, there's a benefit of having the high diuretic dose, because that causes more weight loss and more net fluid loss in these patients. Acetylizumide which is a carbonic anhydrase inhibitor, which is an old drug but has been recently looked at it in an ADVOR trial in the term of the decongestion of this patient, and the primary endpoint of decongestion, which was measured as a congestion score, was achieved and 42.2% of the patient on the acetazolamide versus placebo in the 3 days, which was significant. And at the time of discharge, there was as well as significant number of the patients who were achieved decongestion. However, the composite endpoint of any cause of death hospitalization for heart failure during follow-up was not difference between these two groups. Why we are so unsuccessful decongesting of these patients? The mechanism was multifold. This is due to splenic congestion, reduced renal perfusion and filtration, cardiorenal dysregulation, and diuretic resistance, which by itself can have a different mechanism, including the difficulty to binding to albumin due to hypoalbuminemia, the decreasing of the renal perfusion, and distal and proximal sodium reabsorption. So the unmet need for treatment of the patient with acute decompensated heart failure recently spurred an interest in developing some device therapies. Most of these therapies are in clinical trials, but I felt it's worth to mention just since they're coming, and you probably will see them in your institution, either in a trial and hopefully down the road more as an option for treating this patient. So the focus of those therapies has been focused on decreasing venous pressure, increasing renal arterial flow, selective vasodilated renal arteries, and removal excess fluid. For the purpose of talks, we focus on these two groups as decreasing renal venous pressure, also known as puller devices, or increasing renal artery pressures, or known as a pusher devices. One of these devices is a precardia device. This is a SVC occlusive device. It's a catheter-mounted balloon, which is placed right above the RA and SVC junction, and it inflates intermittently has a regulation of the cardiorenal interaction. In the early feasibility study of a venous HF trial, the primary endpoint was a freedom from device or procedure-related major adverse event, which was met in all 30 patients enrolled. Secondary outcome was related to the hemodynamic. The RA pressure was decreased by 34%, wedge was decreased by 24%, and renal, that was not in the cost of the acute cardiac index or mean arterial pressure. And urine output was increased significantly in the group who are treated. Some of the proposed mechanism of action of the precardia, including to moving the volume to the more favorable place on the Frank-Starling curve. As we know, as we increasing the end diastolic volume, the stroke volume will increase, but especially in the heart failure and the extreme end diastolic pressure, the heart operates on what is called descending arm that decreasing the stroke volume. So we try to modulate that. And also improving the stroke volume based on interventricular interdependency and decongestion of the right ventricle so the left ventricle can work more efficiently. And then lastly, it has hypothesized, when we also have we have published on that increasing the urine sodium excretion during the therapy with this device. The other device, which is one of our other devices, which is known as the pusher devices, is Prostelion aortics. This is in a trial. This is a device that's placed in the descending aorta right above the renal arteries and increasing the perfusion directly to renal arteries. In the initial trial, there was 30 patients enrolled, 21 patients treated with this device, and the hemodynamic parameters, as we see over there, the CVP wedge was decreased significantly. There was improvement of the kidney function immediately after therapy and 30 days of follow-up, as well as the GFR, and there was the improvement of the symptomatic and dyspnea of the patients. There are a lot of these devices are coming to the trial and the market, so it's good to be aware of it and be hopefully contributing to understanding these devices more, so we can have more options for our patients who come with acute decompensated heart failure. So take-home points: cardiorenal syndrome involves complex interaction between heart and kidneys. Prompt identification and diagnosis of a cardiorenal syndrome is crucial to improving the patient outcome. Cardiorenal syndrome is categorized into different types, and acute cardiorenal syndrome, or type 1, being the most common and something that we deal most frequently with. The fundamental aspect of treating cardiorenal syndrome involves reducing the preload, and management should be tailored to the underlying cause of condition. And there are a lot of research is going on in this area, and we are excited to be part of it, and hopefully we can be able to serve our patients better in this arena. Thank you so much for your attention.
Thank you so much for that wonderful talk. I was really excited to hear about cardiorenal syndrome because I think it's not just a complex interaction between the heart and the kidneys, but also sometimes between the cardiologist and the nephrologist.
Yes, exactly.
It's always a battle. I don't know if there were any questions, but one thing that I wanted to ask was early recognition is what we talk about. What is the best way, and this may be for the panel and Dr. Yousefzai, what is the best way to do early recognition? I know there's always a conversation about, do we take the patient for a hemodynamic assessment? Do we just push diuretics and see if the renal function gets better? Do we back off and fluid challenge? What is the best way to?
Yeah, I think as you mentioned, the early recognition is a key. And however you do it depends on the various scenario of the patient. You know, first we have to look at the patient and to see what's going on with the patient. And if there's a patient is congested, warm, this is a patient you need more diuretics. There are patients that obviously is cold, is more in the shock. With this cardiorenal, most of the patient we deal there in the kind of pre-shock type of scenario. But if they're in shock, the early recognition and acting as fast as possible is a key, either by inotrope or escalating to the mechanical support. But as you said, there's a lot of discussion. We do this rounds as a cardiorenal rounds with the nephrologist, which was very helpful to understand and to talk to each other to see where they get our points. But if there's any question and we really want to know, we don't know exactly what's the right way to do it, I think we really have to move to a better understanding about hemodynamic assessment. That always helps with the right decision.
So Ryan, I appreciate those comments. I agree. I think in the end you want to keep it simple, right? They're overtly volume overload. They're in the hospital with acute decompensated heart failure, and their kidney function is getting worse, or they're not, or they have persistent refractory volume overload. And you have to decide: are you going to double down on the diuretics? Do you need any other form of support? And so preload reducing is afterload reducing for the kidney. So it's all about the CVP. Now, if you go to the bedside and someone has 3+ edema, CVP to the angle of the jaw, and their creatinine's getting a little bit worse, and their blood pressure is stable, you're going to double down on the diuretics. But when we have journal club with the nephrologist, it's like, how fast? Do we hold? Do we need to give sodium? So there's a lot going on. I think there's a real role for hemodynamic profiling and early use of SWAN. And these are evaluations that should be happening 2-3 times a day in that patient admitted to understand if they're having a favorable response or not. And so we'll put a SWAN in, we'll have a CVP goal, an SVR goal, cardiac index goal, and a mean blood pressure goal. Because you want to preserve arterial filling to the kidney. The preload to the kidney is arterial filling. What are the metrics? Blood pressure, cardiac output, cardiac index. And you want to minimize afterload for the kidney, CVP. Some people are preload dependent. You can't go as fast. But if you're not tracking it hour by hour in a patient that's already declared themselves, then you're not as well positioned to understand whatever you decide to do, whether it's working or not. So yeah, I think early hemodynamic profiling is key. And I wanted to ask, over the next minute or so, your stance on next step therapies when doubling down on the diuretics, even if you have a high CVP. When do you use temporary mechanical support? Intro to balloon pump to improve cardiorenal, an Impella CP, an Impella 5.5, let alone other devices outside of what's being studied in research protocols.
Yeah, I think that's a great question. I'm in ICU right now. We just had a discussion right before coming. There's a patient. He's congested. His cardiac index is not that bad, but we are pushing diuretics and he's not responding. So this is a time for me, I think, to pull the pressure. That's why the early hemodynamic profiling is very important, because we have a SWAN and we know what the wedge is, we know what is the CVP is, what the rate of response is, and if it's not appropriate, the earlier we can get decongested this patient, the outcome is better for this patient. So early recognition, and I think I would not sit on this patient for a long time if they're not responding. I could move to the MCS, either balloon pump or Impella fast. Yeah.
Most excellent.
Thank you so much.